सुन रहा है? And in that we talked about suture materials, and we also talked about the various types of knots, है ना? And then we should also talk about in general surgery about the various types of needles and the knives we have. Now, first of all, we should know these are the knives we have, the surgical knife blades. In these surgical knife blades, these are the surgical knife blades we have. For us, the important one is 11, 15, 22 and 23. Actually, 23 is also not important. Why? Which is important, I'll let you know. First of all, see, you can see 11 number knife. This 11 number knife is the most important knife, surgical blade for us. This 11 number is also called a stab knife. This 11 number is also called a stab knife. And this 11 number knife blade, we are going to use whenever we are going to open any cavity. Any hollow viscera, if we want to enter into, we need a stab knife. So say for example, if you have to drain abscess, the abscess cavity, abscess as a cavity, so we give a stab incision on that and let the pus come out. So this stab knife is primarily used for a cavity. So if you are asked that you are supposed to do arteriotomy, what is arteriotomy? Opening of an artery and then closing it back. So how will you open any artery? Artery is a hollow thing, so you use a stab knife. Similarly, you are told to do enterotomy, intestine, opening intestine and then closing it back. So again, for intestinal opening, you have to enter with a stab knife. Okay. Now, 15 number knife, surgical knife blade which you are seeing is a knife blade which we are going to use for any minor surgical procedure. Any surgery which you are going to do in a minor operating room, or any surgery where the size of the incision is not going to exceed more than 2 centimeters. Sebaceous cyst removal, dermoid removal, hydrocele, all these surgeries we are going to do by using a 15 number knife blade, which is a knife blade used for minor surgical procedures. For all laparotomies or thoracotomies, big incisions, for all laparotomies and for all thoracotomies, the bigger incisions, we either use a 22 or 23. We commonly use 22. We commonly use 22. And then there is a 20 number knife also, which is not there in the image, which is more or less like a 10 number only. 20 number knife we use for all procedures in between minor and a laparotomy procedure. So say for example, you're doing appendectomy, or you're doing a cholecystectomy, or you're doing hysterectomy, or cesarean sections, all incisions which are smaller than a laparotomy incision but bigger than a 2 centimeter incision, we will use a 20 number knife. Okay, so this is how we are going to decide about a surgical blade. Now coming on to the needles. First of all, we need to know the nomenclature in the needle. If this is a needle, if this is the needle, earlier what we used to have, earlier we used to get needles with a eye like this, and we used to put a suture in that eye earlier. We don't get these kind of needles anymore. Now we get needles with a suture already inside the end of the needle. So the point where the suture is inside the needle from the manufacturer side is called swag of a needle. Swagged end. So the end where the suture material is inside the needle itself, that part of the needle is called swagged end. And then there is a tip of the needle also. Now in tip of the needle, very important, we can have a taper cut needle. We can have round body needle. We can have a reverse cut needle also. We have taper cut, we have round body, and we have reverse cut also. Now in a round body needle, as the name suggests, what happens is whole body of the needle you will find is going to be round. The only thing which is tip is going to be pointed like this. Tip of the needle will be pointed like this. Whole rest of the needle, the whole part of the needle will be round, except at the tip there is a pointed end. So when you find a needle with a tip having a pointed end, that kind of a needle is called a round body needle. Okay, and then there is a taper cut needle also. In that taper cut needle, you will find a cutting prism. There is a prism cutting part of the needle like this. There is a cutting part of the needle like this. This cutting part is on the inner circumference of the needle. When you find a cutting edge on the inner side of the needle, it is called a taper cut needle. The cutting prism on the inner circumference of the needle, if you find, it is a taper cut needle. And if you find a needle with a cutting prism on the outer circumference like this, it is a reverse cut needle. It is a reverse cut needle. Now, coming on to which needle are we going to use when? Now, all delicate structures which are so delicate that they are not going to offer any resistance to once you go inside them. You just need an entry point in them, and once you enter, they will not offer any resistance. They are called delicate structures. So for all those delicate structures like intestine, like vessel, like a subcutaneous layer, like a fatty layer, these are all delicate structures. For all such delicate structures, we just need an entry point. And once we enter, the tissue is not going to offer any kind of resistance whatsoever. So such delicate structures, we use a round body needle. आपने किसी स्ट्रक्चर के अंदर टिश्यू के अंदर डाला निडल, एंड द निडल इज गोइंग स्मूथली थ्रू दैट. आपको कोई रेजिस्टेंस मिल ही नहीं रहा, आप बिना कुछ फोर्स लगाए अंदर ग्लाइड कर जाओगे. दैट इज अ डेलिकेट स्ट्रक्चर. So for all such delicate structures, you use a round body. For all tough structures, those structures which are going to offer resistance to their passage through them, like tendon, like aponeurosis, like bone, they're all tough structures. they are going to offer resistance all throughout their passage. So such structures, we need a taper cut net. And especially for skin, which is again a tough structure, especially for skin, we use a reverse cut net. Especially for skin, we are going to use a reverse cut net. So these are the things we should know in our surgical skill part of general surgery. Okay, then we talked about the various types of sutures. Let me confirm. We talked about the types of sutures and where to use what suture, right? Then we also talked about the various types of closures. We talked about Jenkins rule also, right? Continuous suturing technique, interrupted suturing technique. In that interrupted, we talked about a simple suture and a mattress suture. Then we talked about various types of knots. Then we also talked about the various types of surgical blades and also, okay, now then comes in general surgery a discussion on hernia. Can you tell me what is hernia? Outpouching of the intestine. Any organ. So if I protrude my tongue, it will be hernia.
In the abdomen.
Yeah?
Abdomen.
Abdomen. Only in abdomen. Protrusion of viscus. Protrusion of viscus or part of the viscus through a opening in the wall of its containing cavity. Protrusion of viscus or part of the viscus through a opening in the wall of its containing cavity is hernia. Now, can you tell me what is the most common hernia? Very good. It is the most common hernia is inguinal hernia. Most common hernia is what is the most common hernia in females? It is inguinal hernia. Remember, be it male, there is no gender bias. It is inguinal hernia for both males and females. Okay. Now, let us know the latest thing in hernia because they can ask you this question. There is something called growing hernia. What all hernias comes in growing hernia? Can anybody tell me? Inguinal to aayega hi aayega. Who said esophageal hernia? Whose esophagus is growing? Nation wants to know. और आने दो. और कोई? अपने मन के हरनिया मत बनाओ. Femoral hernia. Inguinal hernia itself forms a scrotal hernia. Okay. Okay. Then there is something called ventral hernia also. Now let me first give you the definition. And then I'll ask you, what is your take on this ventral hernia? Ventral hernia are those hernias which are coming out from a anterior abdominal wall fascia. All those hernias which are coming out from anterior abdominal wall fascias are called ventral hernias. Now, with this definition in mind, can you tell me what any ventral hernia you know? Very good. Very good. Umbilical hernia. Any other? Inguinal तो groin में चला गया, तो जगह थोड़ी ले लेगा. It is not coming from anterior abdominal wall fascia. Huh? Which hernia? Navel? Any hernia? What is that called? There is a name to that. Hindi it is called incisional hernia. So it is incisional hernia. What is that? Any other hernia? Epigastric hernia. एग्जाम में नेट काम नहीं आएगा. Any other? Umbilical? Any other? Spigelian hernia, and then lumbar hernia also. Lumbar hernia. हाँ तो anterior थोड़ा यहाँ तक तो आ रहा है, right? These are the ventral hernias where so they can ask you which of the following is not a ventral hernia. Now let us know one thing, few things which are common to all ventral hernias, and few things which are common to all groin hernias. So let's keep the things simple. We don't have to remember for every hernia separately. These are the common things which will be applicable for any hernia. In ventral hernia, the most important reason for all ventral hernias is increased intra-abdominal pressure. Most important reason for all ventral hernias is increased intra-abdominal pressure. And first investigation for all ventral hernias is ultrasound, while the investigation of choice for all ventral hernias is CT scan. So you don't have to remember for every hernia individually now. I'm trying to keep the thing simple for you. Now for all groin hernias, the most important reason is weakness of the muscles. The first investigation here will be ultrasound. Investigation of choice here is MRI, while gold standard is laparoscopy. Now coming on to inguinal hernia. Let us talk about inguinal hernia now. Inguinal hernia can be congenital, can be acquired. Inguinal hernia can be congenital, can be acquired. Which is more common? Acquired inguinal hernia is more common than a congenital. Congenital inguinal hernia is due to presence of patent processus vaginalis. What is the most important reason for acquired inguinal hernia? Weakness of muscles. Now, inguinal hernia can be on the right side, can be on the left side. Which sided inguinal hernia is more common?
So right side.
So you should always be on the right side of right people. So right-sided inguinal hernia is more common than the left. Then inguinal hernia can be there in males, can be there in females. More common in?
Males.
More common in males. More common in males. Inguinal hernia can be indirect, can be direct. Indirect or direct more common? Two choices. Indirect inguinal hernia is more common than a direct inguinal hernia. Huh? What does अभी आया picture बाकी है. Indirect inguinal hernia is more common than a direct inguinal hernia. And very important point, this is the latest. Indirect inguinal hernia is also called lateral hernia. Direct inguinal hernia is also called medial hernia. You will write L for this, you will write M for this. Okay. Now, what is it lateral to and what is it medial to? Important point. Indirect inguinal hernia comes out through a deep ring. If this is the inguinal canal, this is the deep ring and this is a superficial ring. Imagine this is a deep ring and this is a superficial ring. And if this is the inguinal ligament. If a hernia is coming out through a deep ring, it is indirect inguinal hernia. If a hernia is coming out through this triangle, this triangle is called Hasselbeck's triangle. Now, what is this Hasselbeck's triangle? And what is the deep ring? And where does this deep ring lies? Very important question. What is this deep ring? What forms a deep ring? Very good. Very commonly asked question. It's a opening in fascia transversalis. Deep ring is an opening in fascia transversalis. And where does a deep ring lies? A very commonly asked question again. Where does a deep ring lies? Deep ring lies, anatomy हो गया 1.25 centimeter above mid inguinal point. This is a very commonly asked question in your exam. What is the difference between a mid inguinal point and middle point of inguinal ligament? Mid-inguinal point and middle point of inguinal ligament are very commonly asked questions. What is a mid-inguinal point? Can anyone tell me? Mid-inguinal point is center of line joining anterior superior iliac spine. Center of line joining anterior superior iliac spine with pubic symphysis. The center of line joining ASIS to pubic symphysis is called mid-inguinal point. What is middle point of inguinal ligament then? It is the center of line joining ASIS with pubic tubercle. So please be very careful about it. Then what forms the boundaries of Hasselbalch triangle? Can anyone tell me? If this is a triangle, Hasselbalch triangle, what are the boundaries? The medial boundary of this Hasselbalch triangle is found by? Very good. Lateral border of rectus muscle and sheath. The lateral boundary is found by? एक मिनट आते हैं वहां पे. Inferior epigastric artery. Base is found by reflected part of inguinal ligament. अब कौन सी वाली लास्ट टाइम बोल रहे थे बताओ. ये लो. अभी ये कर ले खत्म. ये हो गया? नहीं हुआ? अब हो गया? ठीक है. हो जाएगा, हो जाएगा, चिंता मत. दुआ कर, हो ना हो जाएगा. So these are the boundaries of a Hasselbalch triangle. Direct hernia, very important, is rarely seen in pediatric patient and in females. Direct hernia is rarely seen in pediatric patients and in females. Then in hernia, so that means this lateral and medial is in relation to what? Inferior epigastric artery. If the hernia is lateral to inferior epigastric artery, it is called indirect hernia. If the hernia is medial to inferior epigastric artery, it is called a direct hernia. Now coming on to There can be intestine there as a content in hernia. There can be omentum there as a content in hernia. When intestine is there as a content in hernia, what is it called? Enterocoele. When omentum is there as a content, it is called omentocoele. Now, out of enterocoele and omentocoele, which is more common? You are absolutely wrong. Omentocoele is more common than a enterocoele. Now, these are the things you already have idea about. Now, we should know what are the various named hernias we have. We have Litter's hernia. What is Litter's hernia? Litter's hernia is one where Meckel's diverticulum is present in the hernial sac. When a Meckel's diverticulum is present in the hernial sac, it is called Litter's hernia. Then there is something called Amiens hernia. What is Amiens hernia? When appendix is present in hernial sac, it is Amiens hernia. Then we have Madel's hernia. What is Madel's hernia? When a W loop of bowel is present in hernial sac, it is called Madel's hernia. Then there is something called Richter's hernia. Richter's hernia is when a part of circumference of bowel is present in hernial sac and is gangrenous. When a part of the circumference of the bowel is present in hernial sac and is gangrenous, it is called Richter's hernia. Then, very important, there is something called sliding hernia. Now, this sliding hernia needs special mention. See, please try to understand that we already have talked about that hernia is nothing but a outpouching of a viscera or a part of viscera. Now, in this outpouching, protrusion of viscera or part of the viscera, okay. Now, in every hernia, there is a sac. Every hernia, be it a ventral hernia, be it a groin hernia, every hernia has a sac, except one hernia, which we'll talk about. All hernias have a sac. And this sac of any hernia is formed by a peritoneum. So sac of a hernia is nothing but a peritoneum. Inside this sac, there can be intestine like this. There can be omentum like this. If it is intestine, it is enterocoele. If it is omentum, it is omentocoele. So in hernia, most of the time, the contents are inside the sac. Sliding hernia is a very peculiar type of hernia. In a sliding hernia, one of the wall in sliding hernia, one of the wall of a sliding hernia, one of the wall of the sac, one of the wall of sac is formed by viscera. Most of the time it is a posterior wall which a viscera is forming. So one of the wall of the sac in a sliding hernia is formed by a viscera. This sliding hernia can be right indirect sliding, can be left indirect sliding, can be left direct sliding. Out of these various types of sliding hernias, more common is a left indirect sliding. More common is the left indirect sliding. And the viscera which is forming a wall in right indirect is cecum. In left indirected, sigmoid colon. In right and left direct, it is urinary bladder. In a right indirect sliding, the viscera which is forming a posterior wall is cecum. In left indirect sliding, it is sigmoid colon. In right and left direct sliding, it is urinary bladder. So if I ask you now, which viscera more commonly forms a posterior wall in sliding hernia, what will that be? A very commonly asked question. And sliding hernia, you should know, is also called hernia NEET. Sliding hernia is also called hernia NEET. Okay. Now, can you tell me what is the most common presentation of any hernia? Tenderness cannot be a presentation. Tenderness is always a sign. किसी को हर्निया हो गया तो आपके पास क्या कह के आएगा? Abnormal pouching को क्या बोलते हैं? Swelling. Most common presentation is swelling in groin region. So most common presentation of these patients is swelling in groin. Right? Now, hernia can be reducible. Hernia can be irreducible. Hernia can be obstructed. Hernia can be strangulated. Hernia can be reducible. Hernia can be irreducible. Can be obstructed. Can be strangulated. Now, what is a reducible hernia? When a hernia goes back to parent cavity, it is called reducible hernia. And reducible hernias have a cough impulse present. When you ask this patient to cough, the swelling will come out and it will increase in size also if it is already there. So this is called cough impulse positive, right? Now, very important point, can anyone tell me that on the basis of this reducibility, can you make out on a clinical examination whether the patient has an intestine as a content or a omentum as a content? Yes or no?
Sir.
Yes or no?
Yes.
Yes. How? इंटेस्टाइन पता चलेगा मोटा सा, और ओमेंटम मोटा नहीं होगा, पतला होगा, नहीं होगा, फिर स्वेलिंग तो दोनों में होगी ना. Omentum will not reduce. Okay. In intestine, this is what they commonly ask in your exam also. If intestine is there as a content, when you try to reduce the hernia, the first part, when you try to reduce it, the first part will have difficulty. First part will find it, you will find it difficult to put it back to the abdominal cavity, while the last part will go back easily with a gurgling sound. First part will have difficulty, while the last part goes back easily with a gurgling sound. In omentum, it is other way around. In omentum, it is other way around. That is, the first part goes back easily, while the last part goes with difficulty. Okay. Then sometime we have to do certain maneuver to reduce the hernia also. When we have a patient with a very big size hernia, inguinal hernia, to reduce the hernia back, we may need to do a certain maneuver. What is that maneuver called? We need to know, and what we do in that maneuver, we need to know. That maneuver is called plss. What is this plss? Plss is a maneuver to reduce hernia. Plss is a maneuver to reduce hernia. And what we do in this plss, we do flexion and internal rotation of hip. Plss is a maneuver where you do flexion and internal rotation of the hip. And once you do this, there was a question asked in a plss maneuver, which muscle gets relaxed so that the hernia reduction becomes easier? It relaxes external oblique aponeurosis. This plss maneuver relaxes external oblique aponeurosis. Then comes a irreducible hernia. Irreducible hernia fails to go back. When a hernia fails to go back to its parent cavity, it is called irreducible hernia, right? And in irreducible hernia, cough impulse is absent. Impulse on coughing or cough impulse will be absent, right? Now, then comes obstructed hernia or strangulated hernia. Obstructed hernia is irreducibility with obstruction to the contents of hernia irreducibility with obstruction to the contents of hernia is called obstructed hernia, while strangulated hernia is obstructed hernia with vascular compromise of contents. Obstruction with a vascular compromise of the content is strangulation. Now, can anyone tell me, strangulation is a forerunner of obstruction or obstruction is a forerunner of strangulation? सोच के बोलना, पहले चिकन आया या एग, पहले ऑब्स्ट्रक्शन होगा या स्ट्रैंगुलेशन होगा? पहले क्या होगा? So strangulation is not a forerunner, na? Obstruction is a forerunner of strangulation. So obstruction का अगला process है, and both these types of hernias are going to be operated in emergency. And very, very important point, the earliest symptom of strangulation, very commonly asked question, is a colicky pain in sac changing to continuous pain. Colicky pain in sac changing to a continuous pain is the earliest symptom of strangulation, while the earliest sign of strangulation is tenderness. Earliest symptom of strangulation is colicky pain changing to a continuous pain, while earliest sign is tenderness. Okay, now normally in a case of hernia, please note this point, we don't need a investigation. Normally we diagnose hernia on the basis of clinical examination itself, but sometime if there's a doubt, we may need to do investigation. So if you have to do investigation, what will be your first investigation? And if on ultrasound there is still a doubt, then it is MRI. And if there is a doubt on MRI also, laparoscopy, then it will be laparoscopy. Okay. So if you have a clinical suspicion of hernia and you are not clear about it, you should do ultrasound as your first investigation. So if they ask you on your providing a clinical profile of the patient. What investigation you'll do? The first investigation you'll do will be ultrasound. If there's a doubt on ultrasound, then the next investigation you'll do will be MRI. Okay. Now, in management of hernia, very important discussion, and this is what they commonly ask also. In every hernia, remember, is a rule. There are two surgeries, it is actually one surgery, but there are two steps in one surgery. The first step and a second step. The first step is herniotomy. In any hernia surgery, the first step is always herniotomy. What is herniotomy? Opening of the hernial sac, reducing the contents back, and then closing it. So that means herniotomy is the basic operation in every hernia, except, very important, हर hernia में herniotomy होगी, except direct hernia and sliding hernia. क्यों नहीं करेंगे स्लाइडिंग में? क्योंकि स्लाइडिंग हर्निया में विसरा नहीं सैक बनाया हुआ, तो अगर आप सैक को काटोगे तो आप विसरा को काट दोगे. So you should not do herniotomy in a sliding, good, as well as a direct hernia. Okay, and very important point. Now before that, second step in hernia surgery. In every hernia, herniotomy will happen. That's a basic operation. उसके बाद क्या करते हैं? You all know hernia is nothing but a protrusion of viscus or a part of the viscus through a opening in the wall of its containing cavity. So from the wall of its containing cavity, the hernia is coming. So we have to strengthen that wall from where the hernia is coming. So the second step in any hernia surgery is strengthening of the wall. Second step in any, हमने सर्जिकल साइट इन्फेक्शन कर लिया ना? किया है, सूचर खोलेंगे, फर्स्ट भेजेंगे, करा है ना? साउथहैम्पटन स्कोर, सेप्सिस स्कोर, नहीं सोफा तो ठीक है, साउथहैम्पटन एंड एसेप्सिस किया है, किया है ना? So a second step in a hernia surgery is strengthening of the wall. Or hernia में, please important point, in every hernia we will do herniotomy except these two hernias, and after herniotomy the second procedure will be a strengthening of the wall. Now for strengthening of the wall, there are two ways of strengthening a wall. One of the way of a strengthening a wall is called herniorrhaphy. One way of strengthening a wall is called herniorrhaphy. Another way of strengthening a wall is called hernioplasty. Herniorrhaphy or hernioplasty. What is the difference? In a hernioplasty, we use prosthetic material. That is mesh. In herniorrhaphy, we will strengthen the wall using autologous materials. We will strengthen the wall using autologous materials. Autologous material means like tendon, muscle or fascia lata. अब हम herniorrhaphies नहीं करते. We don't do herniorrhaphies anymore. We just need to know the names of herniorrhaphies. They will not check you on herniorrhaphies because we don't do herniorrhaphies anymore. But still, we should know what are the various types of herniorrhaphies we have. We have Bessini's repair. We have McVay, Cooper's repair. We have Scholdi's repair. And we have Disarda repair. These are the various types of herniorrhaphies we have. We don't do herniorrhaphies anymore. We don't do herniorrhaphies anymore. The only time, please remember one basic point, and that will be helpful in your answering general surgery questions again. In emergency, whenever we do surgery in any emergency, we never put an implant. In a hernioplasty, we are supposed to put an implant. So hernioplasties are never done in emergency. So that means if at all you are doing a obstructed and a strangulated hernia repair, then only you will do hernia repair in emergency. Otherwise, you don't do hernia repair in emergencies. Then is a time we may need to use a herniorrhaphy. And that time, which herniorrhaphy are we going to use? Right? But we usually don't do herniorrhaphies. Only in emergency repairs, we do herniorrhaphies, because in emergencies, we never put an implant. Okay. So we commonly do hernioplasty. Now, very important point to note. I told you, herniotomy is a basic operation in any hernia, except sliding and direct. And herniotomy is the only operation required in a pediatric hernia. Can anyone tell me why? We don't do strengthening of the wall in a pediatric hernia. Why? Not developed. What is the reason in pediatric hernia? What is the reason of hernia in pediatric? Is it a weakness of muscle? Is it a weakness of muscle? Patent processus vaginalis. After this hernia discussion in hydrocele, I'll tell you what is this patent processus vaginalis. This is when a testis descends. You all know. It descends with it is like this. The peritoneum comes down with the testis like this. And in a normal situation, what happens? This peritoneum closes here and closes here. And this whole part goes away. This whole part goes away in a normal situation. Okay. But sometime what happens is this whole part may remain like this. Once this whole part remains like this, the peritoneum is coming down and it is, the viscerals are inside here. So they may come here and form a hernia. So this is patent processus vaginalis. When the processus vaginalis remains patent, instead of getting obliterated, it is called a congenital hernia or a pediatric hernia. So in a pediatric hernia, there is no problem called weakness of the muscle. The problem is the processus vaginalis which fail to get obliterated. So in such hernias, we don't need to strengthen the wall because the reason is not a weakness of the muscle. The reason is presence of patent processus vaginalis. So if we close this, we open hernial sac and close it. We are done with. So this is what is herniaotomy. This is why the herniorrhaphy or hernioplasty is not done in a pediatric hernia. So you should know. Now hernioplasty is something which we do in all the hernias except pediatric hernia. Just I told you that. Now in hernioplasty, there are two types of hernioplasties. Open hernioplasty and a laparoscopic hernioplasty. We have a open hernioplasty and a laparoscopic hernioplasty. In open hernioplasty, we have Lichtenstein hernioplasty. In laparoscopic, we have TEP and TAP. In laparoscopy, we have TEP and TAP. First of all, what is TEP and what is TAP? What is TEP? TEP, TAP. Lichtenstein. अभी तक कैलीग्राफी समझे नहीं तुम लोग. हाई लेवल की अंडरस्टैंडिंग चाहिए. थोड़ा लेवल उठाओ अपना. So Lichtenstein hernioplasty and TEP and TAP. TEP is, what is TEP? Totally extra peritoneal repair. What is TAP? What is TAP? Trans abdominal pre-peritoneal repair. इसमें हमें ज्यादा at your level, you don't need to go into detail much in that. But what you need to know here is this, that both this TEP and TAP, both these repairs, we usually do the same thing. हम same चीज करते हैं. There is only one difference which we need to know. Not detail required. In TEP repair, we avoid creation of pneumoperitoneum. In TEP repair, we avoid creation of pneumoperitoneum, while in TAP repair, we create pneumoperitoneum to do this surgery. You just need to know this. And in both these repairs, out of both these repairs, more commonly done now is TEP. Right? More commonly done is TEP. We don't need to go into the detail of these repairs, but we need to know these things in these repairs. In both these repairs, there are two triangles which we need to know. In both these repairs, there are two triangles which we need to know. One is a medial triangle, and that is called triangle of tomb, not tomb. Triangle of tomb. And then there's a lateral triangle called triangle of pain. Triangle of pain, or which is also called electric hazard triangle. Triangle of doom and triangle of pain. Now, in this triangle of doom, the boundaries of this triangle of doom are important for you. The boundaries are: medial boundary is found by vas. Medial boundary is found by vas. Base is found by peritoneum. Lateral boundary is found by a testicular vessel. Lateral boundary is formed by testicular vessel. In triangle of pain or electric hazard triangle, the medial wall of this electric hazard triangle is formed by testicular vessel, and the base is formed by iliopubic tract, and the lateral wall is formed by peritoneum again. Now, in this electric hazard triangle, the contents are also important. The contents of this triangle are the contents of this electric hazard triangle are lateral cutaneous nerve of thigh, lateral बुला लो इसको lateral triangle of pain, genitofemoral nerve and intermediate cutaneous branches of anterior femoral nerve. The contents of triangle of pain are lateral cutaneous nerve of thigh, genitofemoral nerve, and intermediate cutaneous branches of anterior femoral nerve. Okay. Then these triangles are important for us for our exams. Now, the most common, very commonly asked question, most common nerve injury in laparoscopic hernia repair, most common nerve injury in laparoscopic hernia repair is lateral cutaneous nerve of thigh. Most common nerve injury in open hernia repair is ilioinguinal nerve. Most common nerve injury in open hernia repair is ilioinguinal nerve. most common nerve injury in laparoscopic hernia repair is lateral cutaneous nerve of thigh. Now, how are they going to ask you these questions? Now, see, since they are asking a clinical questions these days, so they will not directly ask you a question like this, that which of the following nerve is the most common nerve injured in a laparoscopic hernia repair. They will ask you a question like this, that the surgeon was doing a laparoscopic TEP repair for inguinal hernia. In a post-operative period, in follow-up, a patient complained of a sensory loss over the lateral aspect of thigh. Which of the following nerve injury is the most common reason? So, same question, but placed in a different way. So, what I'm trying to convey through that is, please orient yourself about the clinical way of exam. The same question will be asked, but in a different clinical format. All the information you already have, but it is all about applying that information through a clinical question, right? In a clinical question. Now, coming on to a repair of choice. Very commonly asked question: what is a repair of choice in inguinal hernia? The repair of choice is Lichtenstein repair. But please be very careful if you are asked what is the repair of choice in a bilateral or a recurrent hernia. Specifically bilateral or recurrent hernia if asked, your answer will be laparoscopic TEP repair. Laparoscopic repair, TEP repair. Okay, now then there is a very commonly asked question further. What is an anesthesia of choice for inguinal hernia repair? Local anesthesia, spinal anesthesia, general anesthesia, vocal and focal anesthesia. It is very good. Local anesthesia. If local anesthesia is fading off, it should be augmented by short general anesthesia. Hernia surgery, they say, is a daycare surgery. Should be done in a local anesthesia. Sublocal. Okay, but laparoscopic repair are always done in general anesthesia. Laparoscopic repairs are always done in general anesthesia, so please be careful about it. Now, should we be giving a prophylactic antibiotic to a inguinal hernia? Yes or no? Why? दिल कह रहा है क्यों देना, रीजन जानना चाहता हूँ. आंसर ठीक है, लिटिल बिट इन्वेजिव. यार देखो, ये लॉजिक मत दो आज की डेट में. हमने डिस्कस कर लिया है कि व्हाट टाइप ऑफ वुंड्स आर यू गोइंग टू हैव. ऑन द बेस ऑफ दैट वी डिसाइड अ प्रोफाइलेक्टिक एंटीबायोटिक. हर्निया में किस टाइप का वुंड बनेगा? क्लास 1, क्लास 2, क्लास 3, क्लास 4. हमने डिस्कस किया हुआ है. क्लास 2 आएगा. देखो No, please don't disappoint me यार. अभी have discussed it in a detail. मेरे को लगा था कि अब तुम्हें समझ आ गया है. अब कैसे क्लीन हो गया? मैंने क्लीन को अच्छा क्लीन बोला था. Clean contaminated. What type of wound will it be? Hernia. 1, 2, 3, 4. 4. आजा आगे आजा 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 मेरे साथ ये हाईएस्ट पे 4 क्यों भाई? नहीं क्यों? अब तो मैं जान के रहूंगा। आगे आगे अरे ग्रॉस पिलेज हो रहा है कहाँ ग्रॉस पिलेज हो रहा है? दिमाग में हो रहा है। हर्निया में आर वी ओपनिंग एनीथिंग देयर विल बी ग्रॉस पिलेज ऑफ माइक्रो ऑर्गेनिज्म? नो. आर वी लीविंग अ कंटामिनेटेड वुंड ओपन फॉर मोर देन 4 आवर्स? नो. तो 4 कैसे हो गया? ऐसे मत कर यार, इतना हमने डिस्कस किया था उस दिन. It is class 1. It's a class 1 wound. Why it is class 2? Are we opening GI tract? Are we opening respiratory tract? Are we opening urinary tract? No. We are just opening peritoneum. Peritoneum opening doesn't mean you are opening a GIT. You are opening peritoneum is a cover. आपने अगर इंटेस्टाइन को खोला तब GI tract के ऑर्गेनिज्म निकलेंगे ना. आपने इंटेस्टाइन खोली नहीं. गैंग्रीनस की बात नहीं कर रहे. अभी हम पहले नॉर्मल समझ ले. अगर कोई पूछे hernia repair is what kind of wound you are going to get? One, it's usually contained in a controlled environment and no GI tract, respiratory tract is open, so it is clean wound. But why are you giving antibiotic? Abhi I'll come to your gangrene wala part. Why are you giving antibiotic when you don't need to give in a class 1 wound a prophylactic antibiotic? Because we are putting a mesh. I wanted to hear that. यहाँ तो कुछ और ही पेंडोरा बॉक्स खुल गया. अरे तुम तो ठीक ही बोल रहे थे. तो it is class 1 and because since we are putting a mesh, that is why we are giving a program. Now coming on to gangrene. If it's a strangulated inguinal hernia repair, then it is class 4. अब ये मत बोलना सर मैं strangulated की बात कर रहा था. Strangulated में बावल गैंग्रीन हो गई. गैंग्रीन हो गई तो सब कुछ निकल गया बाहर. स्पिलेज हो जाएगा सारा. Gangrene is class 4. Obstructed inguinal hernia repair will be class 3. Strangulated will be 4. ठीक है, चले आगे. So this was about our discussion on inguinal hernia. Now coming on to, then comes femoral hernia. Femoral hernia is more common in females. Very important. Please be very, very careful. The most common hernia in female remains inguinal hernia. It is just that femoral hernia is more common in females. There is a lot of difference between the two statements. Most common hernia in female is inguinal hernia, but femoral hernia is more commonly seen in females. Okay. Now this femoral hernia comes out through a femoral ring. I am not going to go into the detail of the anatomy here. Femoral hernia comes out through a femoral ring. This is femoral ring. Since femoral hernia comes out through femoral ring, which is a narrow opening. Since femoral hernia comes out through femoral ring, which is a narrow opening, this hernia has a maximum risk of strangulation. Femoral hernia has a maximum risk of strangulation, a very commonly asked question. And direct inguinal hernia, highlight it in your notes. Direct inguinal hernia has a least risk of strangulation. Direct inguinal hernia has a least risk of strangulation. And femoral hernia, can you tell me what is the most common, will be a most common presentation of a femoral hernia?
Swelling.
It is again swelling in groin. Now, very, very important point. Inguinal hernia also has a swelling in the groin. Femoral hernia also has a swelling in the groin. So, how will you know through clinical examination that whether you are dealing with an inguinal hernia or a femoral hernia? Very important. On examination, pubic tubercle is a very important landmark to differentiate. Very commonly asked question it is. Pubic tubercle is a very important landmark to differentiate inguinal hernia from a femoral hernia. How? If the neck of the sac is above and medial to, if the neck of the sac is above and medial to pubic tubercle, it is inguinal hernia. If the neck of the sac is above and medial to pubic tubercle, it is inguinal hernia. If the neck of the sac is below and lateral to pubic tubercle, it is femoral hernia. Very commonly asked question it is. Right, and then femoral hernia, since comes out through a narrow opening, it is commonly irreducible also. And very important point, because it is commonly irreducible, it can also present as acute intestinal obstruction also. So please be very careful. We'll be talking about that in GIT. A patient coming to you with the features of acute intestinal obstruction, they may provide you a profile. We'll be talking about that in our discussion in GIT. That a patient is coming to you with features of acute intestinal obstruction and you are told that there is a small swelling in the groin, and they can ask you what is the reason of this acute intestinal obstruction. So if there's a small swelling in the groin and the patient is coming to us with features of acute intestinal obstruction, it is femoral hernia. Okay, and this femoral hernia, since has a very high chance of strangulation, we should not delay in operating a femoral hernia because there are very, very high chances of strangulation in this. Now, further, in femoral hernia, Richter's hernia, another important point. What is Richter's hernia? Part of circumference of the bowel is present in the hernial sac and it is gangrenous. Richter's type of hernia is commonly seen in femoral hernia. Richter type of hernia is commonly seen in femoral hernias. Okay, and in femoral hernia, we have various types of repairs also. In femoral hernia, if this is the inguinal crease, and if this is the femoral triangle and this is a femoral ring, if you give incision below the inguinal crease in surgery for femoral hernia, if you give incision below inguinal crease, it is called Lockwood operation. When you give incision below inguinal crease, it is called Lockwood operation. When you give incision on inguinal crease, it is called Lothesian's operation. And when you give incision above inguinal crease, it is called McEverdy's operation. So this is called low approach. And this is also called high approach. Lockwood operation. And out of these various approaches, preferred approaches is McEverdy's approach. Now, they can ask you a question like this. Inguinal crease, ये inguinal crease है. अगर इंसिजन ऊपर दोगे, यहां दोगे इंसिजन तो हाई अप्रोच है. यहां इंसिजन दोगे इंग्वाइनल क्रीज पे तो लोथेसियन अप्रोच है. अगर बिलो इंग्वाइनल क्रीज दोगे तो now they can ask you a question like this. A surgeon is doing a repair for inguinal hernia. On exploration for an obstructed inguinal hernia, the bowel found to be gangrenous. On exploration for inguinal hernia repairs, in an obstructed inguinal hernia, bowel found to be gangrenous. Resection of the segment of the bowel was done. Resection of the segment of the bowel was done. Now, to repair this bowel, which are the following suture and which are the following repair technique the surgeon should use? What technique he should use and what suture he will use? Tell me. Surgeons know. Suture and technique, tell me. Technique is high approach. Inguinal hernia की बात कर रहे हैं. Just because femoral hernia में discussion हो रहा है. बोलो आंसर, ये हम डिस्कस कर चुके हैं. Suture will be vicryl. Very good. Very good. What commonly we are using? Silk. Very good. And what technique we should use? What is that called? Single layer closure technique. What is that single layer closure called? Extra mucosal or Matheson's repair. तो सुना सुना लग रहा है. देखो एक ना मेरी my sincere advice to you, this used to happen with me also. हम जब कभी सब्जेक्ट कोई कर रहे होते हैं, when we are doing a particular subject, that time if somebody asks us question from that subject, we usually able to answer. अगर हम सब्जेक्ट करने के बाद भी क्वेश्चन के आंसर नहीं कर पा रहे, then there is a problem. बट यूजुअली वी कैन डू। जब आप नेक्स्ट सब्जेक्ट पे चले जाते हो, सर्जरी खत्म हो गया, दूसरा सब्जेक्ट शुरू हो गया, आपसे कोई सर्जरी का क्वेश्चन पूछेगा तो आप शायद फिर भी आंसर कर दोगे। जब आप तीसरे सब्जेक्ट पे चले जाओगे तो आपसे कोई सर्जरी का क्वेश्चन पूछेगा तो आप बोलोगे यार ये मेरे को आता है, सुना हुआ है, कहाँ लिखा है मैंने अपने नोट्स में ये भी पता है, बट वो क्या लिखा है याद नहीं आ रहा, जो अभी हो रहा है। और जब फोर्थ सब्जेक्ट पे जाओगे तो सेम क्वेश्चन कोई पूछेगा तो आप कहोगे ये मैंने कभी पढ़ा ही नहीं है, मैंने तो सुना भी नहीं है। तो ऐसे में क्या करें, क्या ये सबके साथ होता है तो सबके साथ होगा। और दिस मेक्स अस disheartened, this makes us give a feeling that that our preparation is not up to the mark because I can't remember anything. But then please don't get disheartened on this. This happens with everyone. This will happen. It is all human because 19 subjects in a time you have is actually inhuman. But then we are doing it. So it is going to happen. So what to do about it? What I used to do, this was a trick which was told to me by one of my very good friends, senior. He told me that what he used to do and it worked for him. So he said, you try doing it also. What we used to do, कि रात को सोने से पहले 1 घंटा पहले जब आप बिल्कुल थक चुके हो, दिमाग आपका बिल्कुल टायर्ड है, कुछ मत करो, आप अपने पुराने कोई भी सब्जेक्ट जो आपने पहले किया उसके नोट्स उठाओ, उसको कुछ याद करने की जरूरत नहीं है, जस्ट फ्लिप द पेजेस। जिसको तुमने वो लाल पीला किया हुआ है ना, सिर्फ उसको पढ़ो, सिर्फ पढ़ो, याद भी नहीं करना, जस्ट रीड दोज लाइन्स। उससे क्या होगा, एवरी टाइम बहुत जल्दी फ्लिप होगा ये, और एवरी टाइम सिंस इट इज कमिंग इन फ्रंट ऑफ योर आईज, तो जब आप अगली बार रिवीजन के लिए आओगे, क्योंकि अगली बार रिवीजन के लिए तो आना ही है, एक बार से तो काम बनना है ही नहीं, तो अगली बार जब रिवीजन में आओगे तो आपको वो नया नहीं लगेगा, आपको लगेगा कि आपको पता है ये, और आप जल्दी उस सब्जेक्ट को खत्म कर पाओगे। सो प्लीज ट्राई डूइंग दैट विल हेल्प यू इन डिक्रीजिंग द नंबर ऑफ डेज you have kept for your revision and one more advice to you। देखो कुछ सब्जेक्ट ना बड़े वोलाटाइल सब्जेक्ट्स है, उन सब्जेक्ट्स को बार बार रिवाइज किए बिना काम नहीं बनेगा, और वो सब्जेक्ट्स बहुत इंपॉर्टेंट सब्जेक्ट है। सर्जरी जैसा सब्जेक्ट है, सर्जरी एक ऐसा सब्जेक्ट है जो आपको करना ही पड़ेगा, या तो आप बिल्कुल छोड़ के जाओगे उसे, अगर आपने रिवीजन नहीं किया हुआ और आपकी रिवीजन नहीं हो रही है, आप कॉम्प्रोमाइज करना चाह रहे हो, तो आप सर्जरी छोड़ दोगे, नहीं यार मेरे से इतना बड़ा सब्जेक्ट नहीं है, बट वो विल नॉट बी अ गुड आइडिया एवर, बिकॉज इतना बड़ा सब्जेक्ट में आप 25 क्वेश्चन छोड़ रहे हो ऐसे ही हवा में, और तुक्के मारोगे उसमें। तो सर्जरी ऐसा सब्जेक्ट है जो आपके किसी और सब्जेक्ट से नहीं कवर होगा, आपको करना ही पड़ेगा, तो सर्जरी के लिए आपको टाइम निकालना ही पड़ेगा। बट कुछ ऐसे सब्जेक्ट्स हैं जो आप टाइम कम लगा के ज्यादा आउटपुट ले सकते हो, और वो सब्जेक्ट वोलेटाइल भी है, और वो सब्जेक्ट दोबारा रिवीजन बार बार भी मांगते हैं। I have seen many students here and I have been in this for quite some time now. I can tell you that pharma, most of you dread pharma. फार्मा से बहुत डर लगता है, फार्मा याद करना पड़ता है, रट्टा लगाना पड़ता है, फार्मा डिफिकल्ट भी लगता है, बट फार्मा इज अ वेरी इंपॉर्टेंट सब्जेक्ट। फार्मा को छोड़ के मत जाना एग्जाम में, फार्मा से मेडिसिन के क्वेश्चन भी हो जाएंगे, फार्मा से फार्मा के क्वेश्चन तो होंगे ही, और फार्मा से मेडिसिन भी कवर हो जाएगी साथ में, और फार्मा आपको काफी अच्छा रिजल्ट भी देती है क्योंकि उसमें ग्रे एरिया नहीं है। सर्जरी में ग्रे एरियाज है, सर्जरी में आप क्लिनिकल क्वेश्चन में हो सकता है आप कहीं पे कंफ्यूज भी हो जाओ, बट फार्मा के क्वेश्चंस होंगे, बायोकेमिस्ट्री के क्वेश्चंस, पीएसएम के क्वेश्चंस, पीडियाट्रिक के क्वेश्चन, ये बिल्कुल स्ट्रेट फॉरवर्ड क्वेश्चंस होते हैं, इनमें ग्रे एरियाज बहुत कम है। तो इन सब्जेक्ट्स को अगर आप अच्छे से कर लोगे तो आप काफी हद तक अपने आप को क्लोज टू 150 के टारगेट तक ले आओगे। तो फार्मा 5 P's, फार्मा, पैथो, फिजियो, पीएसएम एंड पीडियाट्रिक्स, साथ में स्किन, ये 6 ऐसे सब्जेक्ट्स हैं, और एनेस्थीसिया 7 ऐसे सब्जेक्ट हैं जो आप जल्दी भी कर पाओगे और आपको रिजल्ट भी ज्यादा देना। तो इन सब्जेक्ट्स पे छोड़ के नहीं जाना इसको, ये सब्जेक्ट कोशिश करना कि छूटे नहीं प्लीज। और फार्मा, बायोकेम, माइक्रो और स्किन या पीएसएम, आइदर ऑफ देम लास्ट के लिए रखना, मतलब लास्ट के 5-6 दिन में इन वोलाटाइल सब्जेक्ट्स को जरूर करना ताकि एग्जाम में वॉमिट कर पाओ, क्योंकि ये ऐसे सब्जेक्ट्स हैं जो बहुत बहुत वोलाटाइल है, एकदम से गायब हो जाते हैं, बट बहुत स्ट्रेट फॉरवर्ड क्वेश्चंस होंगे इनमें और सीधा सीधा आंसर होगा। जो आपको आता है तो आता है, नहीं आता तो नहीं आता। सर्जरी और मेडिसिन के क्वेश्चंस ट्रिकी होते हैं, आपको अच्छे से चीज समझ आई है, कंसेप्ट आपको आया हुआ है तो आप आराम से कर लोगे और आपको रटने की जरूरत नहीं पड़ेगी ज्यादा चीजों को। तो सर्जरी को आप लास्ट के लिए मत रखो, सर्जरी को पहले करो और उसको रिवाइज हो गया तो हो गया। ये जो वोलाटाइल सब्जेक्ट्स है इन पे ज्यादा ध्यान देना। So this was about a femoral hernia. Then comes, खत्म कर लेते हैं हर्निया, आधा घंटे का बात है बस, आधा घंटा भी नहीं है, 10-15 minutes. Epigastric hernia. Now this epigastric hernia comes out through linea alba. Epigastric hernia comes out through linea alba. Now, since this hernia comes out through, if this is a abdomen, this is umbilicus, and this is the linea alba. So this hernia comes out through linea alba. Since this hernia comes out through linea alba, this hernia is also called fatty hernia of alba. Sorry, this hernia is also called fatty hernia of alba. And since this hernia is coming out through linea alba, this hernia is always above umbilicus. It is always in the midline also. This hernia is always above umbilicus and it is always in the midline. And another very important and a peculiar point about this hernia is usually hernias are seen in individual with a weak muscles. Epigastric hernia is one hernia which is commonly seen in a muscular individuals. And I told you every hernia has a sac. Epigastric hernia is one hernia which doesn't have sac. This is the only exception. And the most common content of this hernia, again a question asked, is pre-peritoneal fat. Most common content in this hernia is pre-peritoneal fat, and in this hernia usually there are multiple defects. And another very important point in this is further, what is the most common presentation of any hernia? Swelling. Most common presentation of epigastric hernia is pain epigastric region. Followed by swelling. And another very interesting point about this pain epigastric region of epigastric hernia, this pain of epigastric hernia mimics peptic ulcer disease. What is the first investigation? What is the investigation of choice? CT scan. And treatment of epigastric hernia is always mesh repair. always mesh repair. That is hernioplasty. Okay, then comes is the speed fine?
Yes.
Then comes umbilical hernia. Now, in umbilical hernia, there are two things. There is an umbilical hernia of infant and there is an umbilical hernia in an adult. And this umbilical hernia of infant is important for us in a way. This umbilical hernia of infant is due to weak umbilical cicatrix. What is this weak umbilical cicatrix? So what happens is in some of the newborns, the umbilicus in initial days is weak. So since the umbilicus is weak, when they cry, you can see a bulge coming out, and when they are not crying, that bulge goes back. So this weak umbilical cicatrix in such newborns leads to umbilical hernia, right? And this is a very commonly asked question that a newborn has taken a birth and there is a swelling which appears in the umbilical region and goes back when he's not crying. So what to do about it? In this is called umbilical hernia of infant, first of all. In such infants, we offer watchful expectancy for 2 to 3 years. What happens is, because of this swelling coming on, crying and going back, coming and going, what happens? The inflammation happens. And because of this inflammation, every time fibrosis is developing. So over a period of time, what happens is, because of this continuous inflammation, the fibrosis keep happening, and this umbilicus becomes strong. So usually, by 2 to 3 years, this swelling goes off. So we don't need to do anything here. We just have to wait for 2 to 3 years. But if the swelling doesn't disappear in 2 to 3 years, then we have to do a primary repair. Only if the swelling fails to disappear after 2 to 3 years, then only we offer a repair for umbilical hernia in infant. Now, can anyone tell me that what suture material should we use for this repair? सोच यार, जल्दबाजी नहीं है. वीक umbilical cicatrix था, उसके लिए आप सूचर यूज कर रहे हो, स्ट्रेंथ देना चाहते हो. पीडीए तो है ही नहीं, पीडीएस है, proline. We should use proline. For any place where we need strength, we use proline. Then this umbilical hernia in an adult. Now this is important. Any hernia in an adult coming out through or around umbilicus is called para-umbilical hernia. Is called para-umbilical hernia. And this para-umbilical hernia is again more common in females than in males. And the most common content of this para-umbilical hernia is omentum. Okay, and in what is the first investigation? What is the investigation of choice? CT scan. And if the size of the defect in umbilical hernia is less than 2 centimeter, you will do a primary repair. You will do a primary repair. And these primary repairs comes by the name of Mayo's repair or Keel's repair. If it is more than 2 centimeter defect, we do a mesh repair. And please highlight it in your notes. Kisi bhi hernia mein, as a rule, remember, whenever we put a mesh, say for example, this is a defect. If this is a defect, if we are putting a mesh, the mesh should be covering the defect 5 centimeter beyond the defect. The mesh should go 5 centimeter beyond the defect. Important point. And this mesh, have you seen mesh? Mesh is like a net. It is like a net, jali, like this. What material should it be made up of? What material should it be made up of? Proline, because it is there to provide strength. So it is made up of proline. And very important point, nowadays, this again can be a question in exam. We use a lightweight, large pore size mesh. Lightweight, large pore size. Mesh कैसे हेल्प करती है हर्निया में? How does it provide strength? बाहर कैसे नहीं आने देती? सूचे से कनेक्ट करते थे तो फिर तो स्वेलिंग फिर भी आनी चाहिए ना, ऐसे तो आगे पीछे तो फिर भी जानी चाहिए स्वेलिंग. तो मेश आपने लगा दी, जाली लगा दी, तो जाली से आगे ऐसे आएगा, फिर वापस चला जाएगा हर्निया पे. तो स्ट्रेंथ कैसे मिली? Mesh is the foreign body. It will incite inflammation, and every inflammation is followed by fibrosis. So what happens is these fibroblasts grows in these boxes, and they form a uniformly fibrotic layer in front of the wall wherever you are putting it. So एक uniform thickness की एक आपने fibrotic layer create कर दी. Once you have created that layer, it prevents the hernia to come out. So how the mesh helps? There was a question also on this. Mesh provides a scaffold, for fibroblast to grow and form uniformly thickened fibrotic layer. So these are the things we need to know in hernia. Now then, I was telling you about that when in a normal descent of the testis, this peritoneum comes like this, the processa venolis, and if this is the testis, this peritoneum gets obliterated here and gets obliterated here, and this whole part in between, this whole part goes away. So this is normal. But if this whole process of analysis stays patent, this discussion is important and a potential question. If this whole process of analysis stays patent, it will lead to congenital inguinal hernia, right? Sometimes what happens is this process of analysis gets obliterated like this. This gets obliterated partly, but like this. So what happens here is, there's a very important point. What happens here is, you can appreciate that there's a partial obliteration happened here, like this, right? So what will happen because of this? The contents which are there inside the peritoneal cavity, they will not be able to come. They will not be able to come. But you know that this peritoneum is a secretory surface. Peritoneum is a secretory layer, so it keeps on secreting fluid. So once it secretes fluid, it will lead to collection of fluid here. So this collection of fluid, which this kind of obliteration leads to, is called congenital hydrocele. Now, what is a very important point about it? Why it was, I told you specifically. देखो इसमें क्या है? Very interesting point. There is a fluid. First of all, what is hydrocele? Hydrocele is collection of fluid around tunica albuginea within tunica vaginalis. Tunica albuginea and tunica vaginalis. These are the two layers. In between these two layers, the collection of fluid happens, which is called hydrocele. Okay. Now, this condition which I have just mentioned to you is a congenital hydrocele, because this is the tunica, this black part is a tunica albuginea, and this whole part which is now persisting is a tunica vaginalis. Processus vaginalis remnant is tunica vaginalis. Okay, so this processus vaginalis got partly obliterated. So there is a layer which is communicating with the abdominal cavity. Now the peculiarity of this is that there is a collection of fluid, but you can appreciate that when this patient stand, the fluid will come down to the scrotum, right? So give rise to a swelling. But when this patient lies down, the swelling, this fluid will go back. So any swelling which is there in the inguinal-scrotal region, which is getting reduced or lying down, what will be your first impression? Your first impression will be hernia. Hernia is a reducible swelling. Usually hernia is a reducible swelling. So this patient will come to you saying that I have a swelling in the inguinal groin region, and which is extending up to the scrotum. When I lie down, the swelling goes off, right? And when you do examination of this swelling, you will find fluctuation, because it's a fluid around the testis. So fluctuation test will be positive. You will be like, what is fluctuation test? You fill a balloon with the water. When you fill a balloon with the water, if you press one side of the balloon with your finger, your other side pops up, right? So same way, in any swelling which has a fluid, when you press on one side, if the other part of the examining finger pops up, it means fluctuation present. So this happens when the swelling has a fluid inside. So this swelling will have a fluid, so it will give us fluctuation. And it has a trans illumination also positive. Any swelling which has a fluid inside, when you put a torch on that, you will see a light going through the fluid. So this is called trans illumination positive. So these 2 points, since they are around the testis, you will call it a hydrocele. But actually, this is not a hydrocele. This is actually a misnomer. This is a hernia. Congenital hydrocele presents as a hydrocele to us, but it is in true sense a hernia. So what is the treatment of congenital hydrocele? The treatment of congenital hydrocele will be a treatment of a congenital hernia. And what is the treatment of congenital hernia? What is the treatment of congenital hernia? Congenital hernia. ये अम्लाइकल हर्निया था, हम इंग्वायनल की बात कर रहे हैं. We will do herniotomy. The treatment of congenital hernia is herniotomy. And what is the best time of doing this herniotomy? The timing of this is 3 years. That's a different thing. Timing of this congenital hydrocele treatment is 3 years, but the treatment is not a treatment of hydrocele. The treatment will be of a hernia. What is the treatment of hydrocele we'll be talking about? Okay? So treatment of congenital hydrocele is a treatment of hernia. That is herniotomy, which is important point. Okay. Then coming on to hydrocele. Hydrocele, I told you, is a collection of fluid inside tunica vaginalis. Between tunica albuginea and vaginalis, no? Primary hydrocele, there are two types of hydrocele. Primary hydrocele and a secondary hydrocele. Which is more common? What is primary and what is secondary? We'll talk about. Out of primary and secondary, which is more common? Primary hydrocele is more common than a secondary. Now, what is hydrocele? Please understand this. Normal kya ho raha hai? This was a processor vaginalis. And this was the testis. Right? In a normal situation, what was happening? This gets obliterated here. This gets covering here of the testis, and this whole part goes away. Right? This is normal. Now, so that means we have this testis like this, having a tunica vaginalis like this. In a normal situation, it will be like this. Agreed, all of you? Now, tunica vaginalis is nothing but a peritoneum only. Processor vaginalis, it's a remnant of processor vaginalis. That is why it is called tunica vaginalis. Now, what happens is, this is a peritoneum. So, this secretes fluid. It has a property to secrete fluid, right? And this tunica albuginea absorbs this fluid. So, in normal situation, no collection of fluid happens around. Okay, but if by any chance, this tunica vaginalis has some problem and absorption of this fluid doesn't happen, with the tunica vaginalis is secreting, so it will lead to a collection of fluid around it. This collection of fluid around it is called hydrocele. Primary hydrocele. What happens in a secondary, and the cause of this non-absorption of a tunica albuginea from tunica albuginea is still not known. Why tunica albuginea fails to absorb is still not known. So it is primary hydrocele. What happens in a secondary hydrocele? As a name suggests, secondary to some other cause, like infection or trauma or carcinoma. In these patients, what happens? Because of infection, trauma, or cancer, this tunica vaginalis start secreting fluid at a higher rate. Tunica vaginalis अब जरूरत से ज़्यादा because of the inflammation starts secreting fluid. Now tunica albuginea is able to absorb, but now the amount of fluid which is released from the tunica vaginalis is quite more than what tunica vaginalis can absorb. So again, the collection around the fluid will remain around the albuginea. So this type of hydrocele will be called secondary hydrocele. तो क्या फर्क हुआ प्राइमरी और सेकेंडरी में? प्राइमरी में the tunica vaginalis is not absorbing. Tunica albuginea is not absorbing. So because of that, the collection is happening. In a secondary hydrocele, tunica vaginalis is secreting more and collection is happening. Now, how clinically both two conditions are going to be different? Let's see. First of all, primary hydrocele is more common than a secondary hydrocele. Okay, so how will a patient of primary hydrocele will present to us? Let me first tell you about a primary hydrocele, and then I'll tell you how it is different from a secondary hydrocele. A primary hydrocele patient will come to us with a swelling scrotum, painless scrotal swelling. A patient of primary hydrocele will come to you with a painless scrotal swelling, right? On examination, you will find scrotal swelling, which is non-reducible. You have to differentiate hydrocele from hernia. So it is non-reducible, getting above the swelling is possible. What do you mean by getting above? When you try to go above the swelling in a hydrocele, because it's a scrotal swelling, when you try to hold above it, you will be able to hold it. But if it's a hernia, try to understand, hernia is coming from the abdominal wall. Inguinal region से आ रहा है hernia और scrotum में जा रहा है. So when you try to hold the hernia, you will not able to go above it because it is coming from the abdomen. You can't enter abdomen. So getting above the abdomen, getting above the swelling is not there in a hernia. Getting above the swelling is there in a hydrocele. Very important difference. Then fluctuation is present and transillumination is also present, and you will find a tense swelling, very tense. It is as if the fluid is trapped tensely inside, tightly, right? And you don't need any confirmation here. Diagnosis is clinical. If there is any doubt, one can do ultrasound. If there is a doubt, one can do ultrasound, but usually ultrasound not required. Okay. Now, how is it going to be different from a secondary hydrocele? What is the difference in secondary? A patient of a secondary hydrocele again has a scrotal swelling though, but here the patient will have pain and swelling will be small in size, not tense, lax, as if the water in the balloon is not completely filled. It is partly filled balloon type swelling. While a primary hydrocele will be a tense balloon, means a balloon is filled to its capacity, right? And there will be the findings related to the condition which are predisposing it. If there is infection, patient may have fever also. If there is infection, patient may have fever also. If there is a history of trauma, patient will give you a history of trauma also, right? So that way, you will have a finding of the cause leading to it also. Okay. Now, in blood in meatus will come when there is a urethral injury. Okay. Now, in this secondary hydrocele, The treatment of secondary hydrocele will be a treatment of the cause. If it is infection, treat infection. If it is trauma, you just have to wait and watch, it will resolve. And if it is carcinoma, you have to manage carcinoma. Okay, treatment of the cause. But in a primary hydrocele, the treatment depends on if it is a small hydrocele or if it's a large hydrocele. In small hydrocele, you do a Lord's plication. In a large hydrocele, you do a Jaboule's procedure with eversion of sac. Plication. In large hydrocele, you do a Jaboule's procedure. देखो इसमें क्या कर रहे हैं हम, just to make you understand. क्या problem है? The problem is tunica albuginea is not absorbing the fluid. This is a problem. So what we do, we give incision on the tunica vaginalis. Tunica vaginalis को हमने खोला और tunica vaginalis को हमने ऐसे किया और जैसे plication, you have seen the curtains. Curtains को plicated curtains होते हैं ना, जैसे ये plications है. इसको हमने ऐसे फोल्ड किया, tunica vaginalis को ऐसे फोल्ड करके इनको आपस में ऐसे सूचर कर दिया. This is called Lord plication, right? इससे क्या हुआ? जो tunica vaginalis है, with the sutures, when you have plicated it, the inflammation happens and fibrosis develops. So these two all layers get adhered to each other, and the secretion of fluid gets decreased because of the fibrosis. Jaboule's procedure में क्या कर रहे हैं? Eversion of the sac. Though because it's a big hydrocele, it is difficult to plicate it. We just evert it. आपने खोला tunica vaginalis को, टेस्टिस ऐसे बाहर आ गई, आपने vaginalis को ऐसे evert कर दिया. जो लेयर थी, जो ऐसे अंदर बंद थी, उसको आपने बाहर खोल दिया. अब ये जो secrete करेगी fluid, जो scrotum है, जो scrotal sac है, वहां से fluid absorb हो जाएगा. So this is called eversion of the sac. So this is how we manage primary hydrocele. So this is what we need to know in hernia and hydrocele. Important point here to note is in hydrocele, fluctuation is positive, transillumination is also positive, and getting above the swelling is also positive. Which in hernia, all these three are negative. Please be careful about it. And hernia can be a reducible swelling. Okay. So this is all about it. Let's take a break here and then we'll talk about it.